you might be seeing. Have you seen any case of cerebral palsy?
Guys, please respond now.
Ma'am, we have not seen any case, but the conditions like spina bifida and
This cerebral palsy.
cerebral palsy.
There and all, how do you think the problem is? It is a lifelong disease, isn't it? From the birth it is starting and it is to lifelong. Children, that it is so the care for the children and the family is entirely different from that of the adult practice. So many issues that caregiver burden, this family issues, socio-economic, it will be affecting the whole family definitely. The other siblings also, the children, other children also will be affected. That is a issue there. So we have to take into account the whole picture. All the things behind the scene also we have to see. Palliative care introduction classes were there, isn't it? There we are giving the total care, that is holistic approach. That you have to keep in mind, holistic approach. The total suffering you have to see. So what are the components of total suffering? What are the components? Palliative care is mainly to improve the quality of life. Palliative care is to improve the quality of life. How will we increase the quality of life? These children and their families, those children suffering from serious health-related suffering and their families. So how can we increase the quality of life? That is what palliative care is doing. So what are the components of this suffering? Can anybody say? This total pain and all you might have you gone through the introduction classes you have gone, na? Anshu, I am seeing Anshu's name, that is why I am calling Anshu.
Yes, ma'am.
What are the components? Pain and all, what are the components?
Like emotional pain.
Physical
pain, emotional pain.
Physical, psychological, social, and spiritual.
Spiritual, yes, ma'am.
These 4 components. So like that. Then the multidisciplinary family-centered approach. Then about the WHO pain ladder. Have you gone through that pain class, adult pain management class? The slide 7, I think. Now the slide 7. WHO, before that on scenario I have kept it. Slide 6. Can you please put the slide 6? Okay, that this is one scenario I am asking. That is a 10-year-old child. 10-year-old child is coming with, it is diagnosed case of metastatic osteosarcoma femur. And child has undergone many treatment. Now he is presenting with the severe pain. Severe pain, and there is, now doctors, oncologists told there is no curative option. This is next slide. After this, next, before this, prior to this. Next one. Oh, next. After the picture. After the. This one, yes. So now the child is came with the severe pain and no curative option. The oncologist told no curative option, and the oncosurgeon advised palliative amputation. So what generally we will be seeing? Child came to us, what normal healthcare workers, doctor or nurse, what they will be thinking? We'll just treat the pain, isn't it? So pain is there, we'll give paracetamol. So this actually what is this for this pain, so many components will be there, isn't it? So once we are not treating all those conditions, we are not, that is why symptomatic. So we have to see the pain, the total pain, we have to see. Total pain concept. Any symptom is there, you have to think as a whole picture, 3D, behind the scene, what is happening. Physical, psychological, social, and spiritual. All the aspects you have to explore That is the why it is different from the conventional management and the palliative management. So let us see what are the sufferings. The previous slides, after this next slide. So total suffering, that is a concept I told. So you have to see all the components. So next slide, please. So this physical, what are the components? Here the child is having pain, isn't it? Pain because of the disease burden itself, because the child is having osteosarcoma. So what all issues might be there? Pain, then swelling, that child may not be able to walk. So already child has undergone many treatments, chemotherapy, radiotherapy, so many treatments child has undergone, biopsy, the procedures, so many. That treatment, part of the difficulties of that treatment, adverse effects of that treatment, then any comorbid illnesses, those issues, those are all components of physical. Usually what is happening is in the conservative treatment, we will be conventional treatment in our modern medicine, we will be seeing this part and we will just treat and send them home. And usually someone will be telling this, no, nothing more can be done. So in palliative care, you should never tell like that. It's nothing more can be done. So never should, okay, hospital like infections, so many things might be complicating this child. Whenever child is going to hospital, means they are at risk of infection. Good. So that physical part usually we will be seeing. So next slide, please. So the psychological component, what is happening compared to adults? The children may not voice their concerns and no one is worried. Whenever a child is coming with parents, you will be simply asking the parents and will be thinking, but we never ask what their issues usually. So they may go unsupported. Actually, we will be asking pain, mother will be telling the child is having pain. So actually what we have to do is their psychological aspect also you have to take into concern. What are the problems child may having this child with sarcoma, they may be very sad. They may be anxious what we are going to do or what will happen in their future life. So anxiety, then definitely they can go for depression because they are very much worried their life has gone changed. Then fear about else in someone has told to amputation also. So they will be very much in feared state, very much anxious. And will be some children, they will be guilty. They will be thinking the mother have told no, don't to play too much. Some other their weird imaginations might be there. They in the mindset of children, they will be thinking because there's something they have done wrong. That is why this much has happened. The guilt feeling. So all these things, unless we explore the mind of the child, we won't be able to manage the pain. So that it is important that you have to explore the children, the difficulties of the parents or caregivers, also the children. Separately, we have to ask. In particular, we have to concentrate more on the child also. Okay, next slide. Then the spiritual issues. This also we are never exploring those things. So spiritual things means what are the issues? Spiritual. There is Rashmi. Rashmi is there. Rashmi. Needu is there. Needu. Is it audible?
And they're responding in chat box. Lakshmi and Anshu.
Responding.
Yes, ma'am. Respect their culture and some kind of punishment from God.
Okay.
And cultural aspect.
Okay. So that is their spiritual means the meaning of life. Their But after this, once getting this disease means they will be thinking, what is the meaning of my life? That someone it is very much faith in God, they may lose faith. Then what is fear of the unknown? What all things are happening in my life? Why me? Why this things happen to me? Also the concerns about the death. When will I die now? What will happen to me after death? What will happen to my loved ones, my parents, my siblings, my grandparents? What they will do if I die? So many concerns will be there in their minds. Also, somebody will be thinking this is all because of my karma, it's destiny. This is my destiny. So their relationship, questioning relationship with God. All these things are spiritual aspects. So this also we have to explore. Unless you explore this, you won't be able to assess the total suffering. So next slide, please. So social aspects. So once the child has got this what some disease means, everyone will be overprotecting. The parents, they will be overprotecting this some infection. They are getting so many issues will be there in the mind. So will be socially isolated. And everyone coming visiting, they will be viewing them as someone different. They won't be allowed to go to school, go to play, go to mingle with the friends. So they will be feeling so much loneliness. They also feeling a fear of being a burden. So they will be thinking they were all those things they were doing independently. Now they need the help of the parents or someone else. So their caregivers help is needed. They are now dependent. So and they are unable to do their routine work. They are losing their social harmony. So these social issues will be there. That also we have to take into consideration. Okay, next slide. So what are the things we have to do in palliative care? So you have to assess the total suffering. Then you have to symptoms. What are the symptoms? Management of the symptoms. Then you have to go for the rehabilitation. Rehabilitation means what all things you have to do for the improvement. So improve the quality of life. That is rehabilitation. Then counseling. The communication is one strong pillar of palliative care. That to make the child and the caregivers understand the all the things about the what is happening to the child, what is going to happen. For all those things we have to counsel with them. And on decision support, that is we have to explain all the situations, what are the treatment they are supposed to get, what are the options. Then if you are explaining everything, they will get confused. They won't be able to take decision by their own. Then what we have to do is we have to support them. We have to support them to how to take decision. We can explain them and we have to be with them so that they can take a clear decision for their child. We have to respect the cultural and spiritual values of the family. Okay, next slide. Oh, okay. This is about the palliative care models. When we are to start palliative care? Ideally, when we are to start palliative care, can someone tell? Can someone tell? This is an important concept. When we are to start pediatric children with diagnosed with carcinoma or when children with chronic disease, when we are to start the palliative care? And please tell if it is coming in the chat box. I am not getting the chat.
Sure,
Okay.
ma'am.
Or otherwise, someone can open and tell. No issues. This chat I am. Let's see. Okay, I know. Respond. Anshu told that it is from the
date of death.
diagnosis.
Yes,
Yeah.
diagnosis.
So you have to start from the diagnosis. The first picture, the above picture, first one rectangle like picture that is showing is the old concept. Previously, it was like that when we will be giving the when some chronic illness or serious illness is diagnosed, we will give the full treatment. And after in the end, what will happen? That it is when the treatment is not working, that time we will tell, okay, then we will introduce palliative care. So it was the old concept. It should not be done like that. The lower on, that is a new concept of palliative care. That is along with the life prolonging care, that you have to start once you are diagnosed with a serious disease, you have to start the palliative care along with the diagnosis of the life prolonging care. That is the new concept we have to follow. So what is happening? The life prolonging care, day by day, you are giving, finally it is narrowing down, and the palliative care, that triangle is getting widened. So what is this hospice care? What is mentioned like that? Hospice care, what is that? This only meant as this. Otherwise, in our setup, it is told as what is that end of life care. That is no role of life prolonging therapy. When at a point, traced at a point where there is no role of life prolonging care is there. So at that point, there will be only palliative and supportive care. That is the end of life care. Maybe some months, sometimes weeks, sometimes days, depending on the particular situation of the child. It may change. The period may change. Generally, it is told us it is 1 year. It is last 1 year like that. It is especially in children. It won't be. We can't predict the prognosis, and the period may differ. So it continues beyond. Like previous slide. This it is continuing beyond that. This is that on triangle again on extended on new triangle. That is, it includes the bereavement care also. That is after death. After death, the care of the after death care. That is grief support to the family. That is bereavement care after the death of the child. We are to supporting the family. That also includes. So that is a new concept. The lower one, that lower this picture is the new concept of the palliative care. Okay, next please. So what is a palliative care need? Actually, there are unmet need, huge unmet need. Global that reported is, WHO is reporting that it is around 4 million children. 4 million children are in need of palliative care, more in the underdeveloped, low and middle income countries. So many unmet needs are there and more in the underdeveloped countries. So next slide, please. So where we have to give the palliative care? Can be done anywhere. Where the child is there we can do. No need of any facility. Whatever facility is there, we can make use of the available resources and give the palliative care. It can be given in the tertiary care facilities, in the community health care, even in their home. In the Western countries and all, this hospice setup is there. And when the child is in the end of life and all, the child and the parents may get admitted in the hospice. So it is not common in India, but this can be there also. So what about this? So no need for this. Ideally, there should be a team should be there, isn't it? Multidisciplinary team, all the team. Even if the team is not there, also we can give. So once you go trained, whenever you get an opportunity to see children with chronic suffering, you need to give the palliative care. That should be our motto. You have to make use of the available resources. And the level of care, according to the specific needs, may change over time. That we know indefinitely. Sometimes the initial stages, they may not need much care. Once they reach the end of life and all, they will be needing the intense support. The day by day, the changes may occur, or within months, child may deteriorate within hours. So in the end of the period, they may require intense care. So depending on the condition and the duration of the illness, the need may change and you have to act accordingly. The next slide, please. So what about the unique needs also? Once similar to adult, each children is unique. Each children and family is having the unique needs because the causes, their illness is different and the mode of death is different compared to adult. Yeah, the adult patients means they will be reporting, I am having this symptom, that symptom, pain, I am having this, I am having radiating pain, like that, they can report. Here, the child is unable to report. Most of the things the parents or caregivers are telling and we are seeing. in younger children, it is very difficult. So lack of self-reporting, and also there are lack of formal assessment tools. In adults, we have so many tools for dementia and all validated tools. In children, for this pain management assessment, some validated tools are there. Otherwise, it is for dementia and all, it will be difficult. For delirium, those things, delirium and all, this is difficult for children. So also the problem is developmental issues. There children are developed by CP child. CP child, there will be their development is affected. So physical issues, emotional needs, all these things differ, and day by day it may change. The CP child at 1 year, it will be different from the 10-year-old CP child. Same child growing up and depending on the developmental needs, their needs, emotional needs, everything will differ once the disease progress and time evolves. So you have to change the care plans accordingly, according to the progression or the condition of the child, change in condition of the child, change in the development, the physical needs, there's emotional needs. You have to assess. You have to change the care plan. So age appropriate empathic sounds one who is practicing or seeing the child with chronic suffering. So you have to be empathetic. You have to be empathetic in the approach, counseling. This age appropriate counseling you have to give. The next slide, please. So support, what else extra compared to adult, you have to extend the support for play therapy. The children is very much into the play. So once you give play, they will be getting so much relief. So play therapy, support for the education. Suppose they are not going to go, they are unable to go to school. Then what we can do? We can tell them, we can inform the teachers and they can send the notes. We can connect with their friends. They will be sending the notes. They can, and we can engage them with the education and the social interaction. So that also important. So because the parents, they will be overprotective, fear of infection, social isolation, all these can harm the child more than the disease. So you have to, that also you have to keep into the mind. So another option, another issue is how to explain the illness to the siblings. The siblings also, they are, after seeing this suffering of their this sibling, they will be coming and asking, what is happening to my brother? What is happening? What is the illness of my brother? Sometimes that also there also we have to explain in a child language. That is a language that is understood by a child. Those things you have to explain. Also, this different management also will differ. Some depend all those treatment and all be given to adult. This not given to the children. So that in the management also some especially in for the pain management also that will tell later. So that also will be, there will be difference is there. The management also difference is there. And when the initial starting I told, in India it is very difficult to accept because they are considered as not supposed to die. Children are not supposed to die, and it is in the pediatric palliative care is in an infantile stage of social acceptance. And it is, we are believing that children are not supposed to die, and so all these are creating social barriers. That also we have to keep in mind while managing a child with chronic health-related suffering. Next slide, please. So many, which are the diseases for palliative care? So many diseases are there. Major things are this prematurity, I will know, premature baby, birth trauma, then congenital malformation. So majority are those diseases. Then all systemic chronic disease, liver disease, renal disease, lung, all this CNS diseases. So malignant neoplasms. Neoplasms are not much high. This major chunks are this prematurity related issues and the congenital malformations. So next slide, please. So this is the expected tragedy. So what is the trajectory of the disease? So in the four types are described in pediatric palliative care. The first one A, that is the trajectory showing child was going normally and there is a unexpected sudden death. It can be about that what is which can you tell in condition where sudden unexpected death can occur? Sonia, can anybody tell where sudden unexpected death? Or you can use the chat or you can open and tell. Child and adults and all we are seeing this myocardial infarction and all. No? That is less common in children. Can you tell anyone? Which condition, in which any condition, very true, and so that is family is not mentally prepared. That is why we are learning these trajectories. Because sudden unexpected death, no parents can accept it. Especially in what condition, especially one example is this myocarditis now. Some normal child, normally developmental child developing the and viral fever, and then affecting the heart, viral myocarditis. The child can die suddenly because it is not at all acceptable to the family, isn't it? So that is the first trajectory. Heart disease, cardiac diseases, they may die suddenly. Okay. So that is the first scenario. So what is the next B? B is from the death from potentially curable diseases. That is, example is cancer. First picture I have shown, 10-month-old child. It is a brain cancer there. It is the disease got diagnosed. What is happening? One dip is there. Because of the chemotherapy, child is getting improved. After again, sometimes relapse may occur, isn't it? Then again, a dip is there. What will happen? Sometimes child will be improving, then child may suddenly contract an infection and may suddenly deteriorate and die. So it is the second picture. That is from scenario. Then third one is, what is that? Third one, the death from lethal congenital anomaly. That we already discussed. Suppose anencephaly at birth. What is happening? Child will within hours or days, child will die. That from the lethal that is the third one. So fourth one, what is that? It is progressive conditions. Progressive neurological conditions, muscular dystrophy. So progressive conditions, what is happening? Child is dipping, again child is getting crisis, some crisis is occurring, again some infection or stress occurring, child is again deteriorating, child picking. So here is the scenario is different. The parents are feeling as if the child is dying again and again. Because every time they are seeing the issue. So they are going to that much mental agony again and again, like that. So these are the commonly described 4 scenarios. So next slide, please. Why it is important? Why we should know this? So another, is it is a little crowded, I will just explain. That is according to the trajectory, these 5 categories are there. One is the first one, that's cancer-like conditions, because life-threatening conditions where curative treatment is possible but may fail. Cancer may treat, some children, it may get cured, like complete cure might be there. Sometimes they may get cure but again relapse. So that is a first group. Then second group is where there is no treatment, cystic fibrosis. There is no treatment. From the diagnosis, we know we will give some treatment, but again, we know that is the child is premature death is inevitable. Then third option is progressive condition with no treatment at all. That is chromosomal disorders and all. There is no treatment at all. Those conditions. Then fourth condition is non-progressive conditions, cerebral palsy. That is anyway affecting the child, but they may recur. They also recur premature death. They may land up with the premature death. That is cerebral palsy. Then fifth condition latest added condition is this unborn child. That is what is called, which palliative care branch is that? Unborn children with the major health problems, who may not live through birth. That infant may survive for only a few hours or days. That is called which branch of palliative care? The perinatal palliative care. That is a fifth option. So these are the 5 divisions, group of diseases according to the expected disease trajectory. So these are the 5 one. Next slide, please. Is it audible now? Clear or not? Is it sound is clear?
Yes,
Yes,
ma'am.
yes, ma'am.
Yes,
why-
ma'am.
Okay, why is it important? Why this trajectory and all? Because once you identify it, early identification, you can recognize the children who will benefit from pediatric palliative care. Then you can tailor the care. So depending on the needs of the child. So the palliative, the different trajectories. The previous slide, please. This one, this same. So palliative care needs differ across these. That is why if it is a chronic condition, the needs will be different. So the needs differ across these groups, requiring specialized approaches to symptom management and support. Also, the resource allocation. So understanding the trajectory of the illness helps in planning and providing appropriate resources for the pediatric palliative care service. Next slide, please. So clinically oriented classifier, that will be more useful to us. That is, one is oncological cases, non-oncological cases, and also some diagnosis may not be there. So many symptoms and all genetic, this workup pending, not get diagnosed. So with no specific diagnosis. So you can simply classify it as like clinically, that is oncology, non-oncology, and with no specific diagnosis. But the problem is each children is unique, isn't it? So the complexity of the each child's and family needs differ. So you have to act accordingly. That is the message. Okay, next slide, please. So what are things we are doing in pediatric palliative care? First, anyway, we will assess, detailed assessment of the symptom. Pain and other symptoms you have to assess. Then you have to assess the family's goals of care. We can make them tell this, we will make the child this 100% normal, like that. We have to assess the family's goals. Each children, depending on the current their status, what is their situation. From there, we are planning some goals for each child, depending on the condition of that particular child at that particular time. So assess that is their goal. Then share decision. Together we have to sit and discuss. The family, ideally we should discuss the child also. So with the family, we have to involve the important persons. Sometimes if you are discussing with father alone may not be sufficient. You have to ask them who else you want to discuss together. We will discuss together. If you want to call your parents, you may call the children's grandparents. So we may involve them also, some uncles, or there's maybe need discussion with this family physician, their family doctor. So sometimes they're political, they're religious. So whoever is important them, you have to include them also in the discussion. Then we can make the that is the shared decision making. So if we are explaining all the options, they will get worried, they will get confused, they will not be able to select one from that. So you have to help them to take the one choice that is in the best interest of the child. That is the shared decision making. What is this advanced care plan? Once the child is diagnosed with a serious suffering, life-limiting disease, we have to have a clear plan. We have to explain the disease, and we have to what are the problems that might be occurring, what are the in the future. Now what all symptoms child is having in the future, what all the symptoms child might have, what all problems can occur. All these things you have to discuss and write down and document it. That is the advanced care plan. So, and care coordination. What all care they needed, we have to coordinate with them. That is our role. Palliative care team, we have to, as a team, we have to coordinate the what all care they need with the different organization, they need with different institution. That coordination also we have to do. Then at the end, there will be end of life care. Whenever the child is some treatment is not working and child is need only this palliative, that transition to only palliative, only option. When the child is nearing the end of life, we have to give the intense end of life care. So these are the main things we have to do in pediatric palliative care. Next slide, please. So the team includes physician, nurses, all of you know, social workers, pharmacist, nutritionist, psychologist, physiotherapist, and also the art and music therapist. Definitely the administrative support. So the entire team available means you have to make use of all the help of all the team. if we finish on there also, we have to do something to the child. Try to do whatever we can do, we have to support them, the child and the family. Next slide, please. So next is relationship building. So first the important pillar. So once you diagnosed with the team is there, you have to get the rapport with them. The whole team have to be in a good rapport with the child and the family. You have to discuss with them what are their needs. The child separately and the family, to all of them, you have to ask what are their wishes, what they desire, what are their desires, what are their worries. Wish, worry, wonder, like that is there. That is wish. What are their wishes? What are they worrying about? What they are expecting? Those things you have to ask them. Once you are actively listening to the child and the family only, we will be able to explore their hidden needs. So explanation of the family's values and beliefs are important. So perception of illness, what they know about the illness in the journey, what all things they know, and what are their goals. So what are in the future. So all these things should be at point, all the points you have to be just in the communication with the family. Next slide, please. So that is this, everybody might be knowing, isn't it? Spikes model. Is the class on communication over? Anyone, please let me know this class. It is over. Okay, then you might be knowing this Spikes model. So what is synonyms of breaking bad news and all? You will be using this. We are systematically following, you will be missing, and you will be more confident. Once you go through this systematic format, you will feel confident. And first there S is for setup. That choose a quite private location and then communicate. So what are the privacies maintained? So it introduced like, I would like to share some news with you. Is there anyone else you would like with you? So if they want to call someone, we can call them, and in the presence we can, that is a setting. So next one is P stands for perception. So you have to ask how much they know. First determine how much the patient or the family know about the illness. So you can ask like, can you share with me what you know about your child's illness? The next I is for invitation. Invitation to share. So ask the family or patient how much they want to know about the illness. Would you like me to share what I know? How much detail do you want to? Some parents today also I have seen one child in the end of life, and there the scenario was inoperable case. It's all on 11-year child at the end of life, but the mother when we hold for the counseling session, the mother was reluctant to come because she was not that ready. She was not that ready to accept the situation. So she told, okay, let father hear the counseling. Please leave me, because she was not ready. So that is the situation. Sometimes they may call my parents also like that. Or they may call their relatives. So you have to ask, are you ready? So then they are ready, you have to give the knowledge. That is care for knowledge, shared medical facts. Use the simple language so that they can understand, plain language, and you have to make sure whether they are understanding. In between, you have to check. So clear the understanding and have empathetic. Empathetically, you have to give that, you have to keep in mind. So then E stands for explore. Explore the emotion. Definitely there will be emotional outburst or emotional, this cry, like emotional. So there you can use the nurse mnemonic. Nurse mnemonic, that I will show later. That here you will be empathetic approach to the emotions. And S stands for the summary. Strategize and summarize. Summarize what all things we have discussed. You have to make plans for discussing the next. That is much important. You have to make sure that we are with them. Make them feel so that they will be supported throughout. Whatever happening, they will be supported. That is the one important thing in the communication. So next slide, please. So then that is a next mnemonic output. Whenever there is emotional outburst, we can use this mnemonic. N start for naming. That is identify the emotion. They are worried. So you can tell like that. So it sounds that you are worried. Then a U stand for understanding. That is a mnemonic U, understanding. Confirm you understand what the patient has said or the parent has said. Do not say you understand what they are feeling. So confirm, are you feeling worried? Or like that you can ask. If you are understand what you are saying, you are worried about adverse effects. Sometimes they may be adverse about the adverse effects of the medicine. So you can counsel what are the worries in there, and once you know, you can counsel in that focused manner. So respecting, that is R is for respecting, validate their experiences and emotions. So like that you can tell this is a lot to deal with. You are doing a wonderful job advocating for your child. What all things they are doing good, they can praise them, and then supporting, providing resources and offer your availability to process. Availability support to tell them we will be here. They can give the contact numbers, can call, so that they will not be left alone. So that we will be together together in the journey. Then exploring, talk through emotions. You mentioned that you are afraid to share this note with your child. Can you tell me more about that? So you can explore what is the underlying lesion. Some hidden issues might be there. There will be simple issues. So we can ask and explore. That is a mnemonic for exploring the emotions. Next slide, please. So the developmental stages. The children's developmental stages affect how they cope with the illness and the dying and the death. So the pediatric palliative care team must have the competence to relate with the children according to their cognitive, emotional, social, and physical stages of the development. And also after 18 years, it may be transitioning to the adult services. So that is another one painful part. These children, especially our CP, those children with diagnosed with CP, and once we will be seeing till 12 years of age, sometimes up to 18 years. Specialty we will be seeing up to 18 years. After that, what is, we will transition them to the adult services. Medicine department, then they will come and tell, no, please come, can you please see to her, because their attitude will be different. They will be seeing, they will be new to them. New doctors, no sisters, no staff there, and they'll be not considered as children anymore. They'll be treated as adult. So that transition you have to make them smooth. So the goals of care you have to change. So cure to the palliative mode, what is happening? You have to be more technology, low technology and high touch, human care, that, and goals, depending on the disease progression, the goals can shift. And the longitudinal relationship is important. That is why that new model it is showing. That is, you have to start palliative. Once you start the palliative care from the early period, you will be in touch with them. Otherwise, what is happening is in the end stage, when the no treatment works, that time suddenly they are shifting to the palliative care, means it will be difficult to make rapport with them, and it will be difficult for everyone. This will be take decisions and all. Once we are with them from the initial stage, we can do many things to them. So family-centered discussion, families' hopes, we can know the family medical conditions, all those things. Families experience, what are the experiences, what are their culture, what are their belief, lifestyle, all this will affect the how we can tailor the care to the particular child. So anyway, in a difficult situation, there will be no right decision, because the best decision is one that aligns with the family's goals. That is the motto. That advanced care planning, already I told, we have to determination of goals and preferences for future medical treatment. And in the advanced plan, it also includes the current management, the future management. It even includes the preferred place of death, preferred setting, preferred place of treatment and death. That also, they even includes the bereavement. This includes the life after death care and also the bereavement needs. All this comes under the advanced care planning. Next slide, please. and the family. Family, what is the benefit if we are including them in our discussions? They should be respected as partners in care, and the care plan should be discussed openly and honestly. And support should be provided, and there should be flexibility. Today, we will be advising on tomorrow child may improve. Sometimes when the child is critical, may tell you the child may die. Sometimes by some miracle may happen. Next day child will be okay. Then there should be some flexibility. So this continuous reassessment, and depending on that current status, you may change the plans. So once we are doing like that, they will have faith with us, and the family involvement will improve the adherence to the treatment. Otherwise, they will be doctor shopping and hoping. They will be going to different centers, different institutions. They will be going. Okay, next slide, please. So shared decision making. Whenever taking a decision, you have to the 4 basic ethical principles should be followed. The ethical principles are this autonomy, that is the right of the individual. They have the autonomy to choose what treatment they have to undergo. And the beneficence, they should be beneficial to the child, and non-maleficence, there is no risk for the child, and the justice. So all this ethically we have to take the decision, that is shared decision making. And the next slide is supporting the families. It is emotional. You have to support them emotionally, financially, the practical challenges you have to see, and counsel them, coordinate the social services and financial guidance we have to give. So family-centered care ensures that they are part of the decision making. And another important area we neglect is respite care. On 12-year-old child, I have shown on picture of a 12-year-old girl with cerebral palsy with so many comorbidities. So what is there for the last 12 years? They are telling many of the mothers, when we are asking about their daily life, they are asking, oh, now I slept some 12 years back, like that. I got adjusted to all those things, all these things, like that. Many mothers are telling, because they are also burnt out, because 12 year means that much. So without support from other members means that will be very this misery to them. So that also we have to keep in mind, this respite care, some relief for them, for the caregivers. And also we have to educate them regarding how to manage symptoms at home. The seizure and all, we can give them this midazolam spray, like that medicine, so that otherwise unnecessarily most of the days we will be at the hospital. If we are teaching them how to simple things, how to manage and all, if we are teaching them, that will be very much helpful for them. Also spiritual support, especially during the crucial time, we have to give them spiritual support also. Next slide, please. So care coordination is important. That is multidisciplinary care of doctors. All the team have to work together and optimize the communication, so that this all can coordinate with this family. The social workers, wellness coordinators can connect the families with the community and the resources for services, and you can connect with the support groups, parent support groups. So they will think, so you are connecting with the children with a similar illness, they will feel more much empowered. So if you are connected with the other support groups, it will be very useful for them. Care coordination is very much have an important role in palliative care. Next slide, please. Next slide. Okay, then management, some only about pain. I have put 4 slides. That is pain assessment. It is, I know I told you now that it is difficult to assess pain. In infants and toddlers, different scores. In adults, we are using which score? It's the pain management class over. Previous slide. Is the pain class over, pain management? Yes, okay. Then what is the scale we are using for adult pain assessment? Pain assessment, which scale is used? How will you assess the pain? Which stage numerical rating scale, isn't it? No, NRS, numerical rating scale, up to 10. On a scale of 1 up to 10, where is your pain? 2, 3, 4, like that they'll be telling. So in a communicating child, you can ask that in a child above 7 years and all, you can ask, what is your pain in a scale of 0 to 10? What is like that you can ask. But in infants, how do so it will be difficult to assess in children. So there will be different scales are available in APS, CRIS, PAPP like that. All. Next slide. Is above 4 years, child can self-report pain. The first one is a faces pain scale revised. That is, you can show this picture to the child and you can ask the child to point it to one particular. We are not seeing the child face and mark. You have to ask the child to which your pain belongs to which picture. Then they will be pointing to one of the pictures. So like that you can scale. Another one is lower down that picture is finger span. How much pain? Little one or more or very big pain. Like that you can ask. That is finger span scale. Next slide. So this is another one that is about 2 months you can use. Flag scale. That is you have to look at the face of the child, the leg, how the leg is positioned, activity of the child, that cry, and the consolability. That is a mnemonic. That is flag scale. For the children aged 2 months to 7 years. Next is for children you can give them body maps. Above 5 to 7 years, can show, ask the child to draw the picture. That is different colors also they can give depending on the severity. The red for the severe pain and this green for less pain. Like that they can mark. Different colors they can use for the intensity. Green for least pain and the red for the most severe pain. So like that also you can ask body maps. Next slide please. Then is the adult tone. We told that is staging that mild, moderate, severe like that 0 to 10. How where the pain is coming 0 or not. It is more than 7 and all. It will be severe pain like that. We can. Next slide. Numerical rating scale or vision analog scale. Next one. So this is what is the difference? You have learned the WHO ladder in adult. What is the difference from that? Can anyone chat or tell? WHO, this is the WHO ladder for pay. Any difference from the adult management of pain? Can anyone tell or can chat also? Can use the chat also? Any difference? You are seeing a difference or same thing for the adult? Yes. What is the difference? Jyoti. How many steps are there here? Ladder for ladder here only 2 steps. Very good. So here only 2 steps are there. What is the difference here? Step 1 is for mild pain. Okay, that is includes only paracetamol and ibuprofen. Here the step 2 is opioids. For adults we use 3 stages. Yeah. For adults step 2 is weak opioids. That is codeine, tramadol and all. It is not recommended children because of not much studies and the side effect profile. Because of that, codeine and tramadol is not recommended for children. Once the child is not working with paracetamol or ibuprofen, so moderate to severe pain, we will be going directly to the opioids, strong opioids. Codeine and tramadol are not recommended in the children. That is a difference in the pain management in the WHO ladder. Only step 2-step ladder. 2-step ladder. The next slide, please. So, like this is a different drugs shown, and depending on you have to assess the symptom, nausea, vomiting, and all. That also here the nausea and vomiting also generally this metoclopramide and all it is having high extrapyramidal symptoms. They may develop dystonia and all. So you have to be careful in the dosing. You have to meticulously the dosing. You have to advise this when you are counseling, prescribe the medicine. We have to be careful and about the dose, and they have to educate them about the side effects also. That is important. And in refractory cases, they can go for other alternative therapy, massage, acupuncture. So other options also we can advise them. Next slide, please. So pain management, for mild pain, already I told, paracetamol, ibuprofen. Severe pain, strong opiates like morphine. And the titration is based on the pain severity and the patient response. So adjuvants may be added for the neuropathic pain. Next slide. So non-pharmacological method play an important role. So distraction, there is pain distraction for, you can use some visual aids or books, some comics, some cartoon like that, or heat or cold packs, as such. So pain should be regularly assessed and caregiver should be educated on the safe dosing. Also educate them about the side effects, and also regular follow-up is needed for the ensure control of the symptoms. Next slide. Psychological care. So emotional support to cope with the illness, the counseling, psychologist and counsel play an important role. Support groups may benefit both the children and parents, and the school liaison. Already discussed that school liaison help maintain normalcy. Art and play therapy can be therapeutic. Next slide. So spiritual care, you have to respect the cultural and religious beliefs. Spiritual leaders, they can involve them also, so that provide hope and comfort and help families find meaning in their experience. And also end of life rituals, depending on their culture, their religion, that should be respected. Next slide, please. Support, social, that you have to support the whole family, the siblings. So most of the time, this what happens is this siblings' education may got affected. So make sure that it is not getting affected, and also they are not getting neglected, because all the family will be concentrating on the child with the serious disease. So you have to make sure that sibling, they also get the proper support. So identify the financial need and connect with the network, this support systems, appropriate referral and support for the legal requirements. So especially for children, this disability certificate, and you have to counsel them, we have to make them aware then their rights, disability certificate, and their benefits of the disability certificates also. And the government schemes, many schemes are there for the government is having, both the state and the central government having different schemes for the treatment of the child. So you have to make them aware to them, so that they may get benefited. Okay, next slide. Hospice, at the end, there will be those who are caring for the actively dying, not common in our setup. They are giving this end of life care, medical, psychosocial, and bereavement support. That is after that support for the family. That is bereavement support. It is generally told that it is 6 months to 1 year. The hospice is palliative care that focus on the comfort, less than 6 months to life. So in other countries, it is like that. Those children will be get admitted to the hospice. Their hospice nurses, social workers, chaplains, child life specialists, as well as 24-hour online access to healthcare provider will be there. So it will be given the medications for the comfort, this durable medical equipment, and legacy building, that memory making, and photos, videos, their hair lock them, these albums, all these things will be made, and they'll be for memory making. All these things will be really done in the end of life care. Next slide, please. So legacy making, that is actions or behaviors aimed at being remembered and can improve the coping and adjustment during illness and the end of life for patients and their families. So the effort should be made to create memories and confirm they are loved and will be remembered are important. Next slide. Also children, they can ask, the children may be having many these wishes. They have to ask them what all things to be done. They may be ask them to try. Generally, they will be communicating through verbal. They usually communicate through verbal, non-verbal, and also through their play. So ask them if there is drawing pictures, then from that, and also we can read their mind through their play. So they needs a special type or simple small wishes might be there. So whatever possible, we have to fulfill their wishes. And coming is animal assisted interventions, is pet therapy and all. This is especially for children with life-threatening condition. So end of life, what we have to do is we have to evolution of the disease. We have to again and again you have to discuss with them. the end of life wishes of the child, that all the symptoms should be treated, distressing symptoms should be addressed, the dignity of the death, that is, we have to improve the quality of death, that is, should be appropriate environment and in the presence of loved ones. So that you have to, family had to be get fully prepared with the dying process. Next slide, please. So this is the first, it's a case initially I told, that is 10-year-old child with sarcoma, now advised for the palliative amputation. So as a team, we have to make them tell what all things can be done, what are the options. We can communicate with them, then we can make a shared decision. Actually, this palliative amputation was advised, so we can shared decision we have to make. Discuss with the child, the parents, and all. Then physician or nurse psychological support for their total suffering, and also the once if it is amputation is decided, if it is decided that amputation is going to do, then the physiotherapist to work with the prosthetic limb and all. So all these measures we can do for that particular child. So depending on the case, each child is unique and you have to see. So next slide, please. So that is a biopsychosocial multimodal approach. So in all the angles you have to see what all things, what child, depending on the our daily life, how it will be managed, the pharmacological, non-pharmacological management, occupational therapy, complementary therapies, their education. So next slide, please. So who is this lady? Can anyone tell? Have anybody seen this picture? Who is this? Next slide. This is next. This is named Cicely Saunders. That is founder of St. Christopher's First Hospice. It is what she told is go around and see what is being done, and then see how your own circumstances can produce another version. There is need for diversity in this field. So each child is unique, and the needs on the children will be different. So we have to assess that and act accordingly. Next slide. Oh, thank you. I hope you have understood about the pediatric palliative care, and if you have any doubts, we can discuss.
Have any doubts, please put it in chat box. Otherwise, you can unmute your mic and ask. Is there any doubts? No, ma'am. Thank you, ma'am. Thank you so much for your kind class.
Thank you, ma'am.
It was very useful for who are doing palliative care.
So next time onwards, if when you happen to see a child with suffering, you have to think, oh, this is okay. Total concept, total suffering, you have to take care of the family all together. The holistic care, that is important. That is the care
Yes,
of
yes.
the body, mind, and the soul. So all things. Just not see the physical, this background, what is happening background, in the background. That also, that is my message.
Yes. Thank you, ma'am. Thank you so much.
Participant, please ask any questions or doubts because we only have 2 more sessions.
Yeah, other pediatric topics are there. Pediatrics, palliative care, another session is there.
Holistic approach, wonderful concept.
Mm-hmm.
Thank you, ma'am.
That is for this course, how many sessions are there for pediatric?
Only 1 session is there.
Only one. Okay, okay.
I think we can wrap it up for today. Ma'am, thank you, ma'am, for your insightful session, and thank you, ma'am.
Thank you.
So, thank you, participants. So, you can leave now. So Jyothi-son, you can message me directly. So I'll clear your doubt. Okay? Okay. So, okay, only 2 more sessions. Okay, all the best, guys. You can leave now. Bye.